we start?
Yeah, we should start now. Neha, please start.
Abhasa, please start.
Okay. Thank you, Neha. Thank you, IIP Raigad, for giving this me opportunity to chair the session on rheumatology and immunology. Let me first take a note that our title of this topic is Pain to Positivity, Navigating Life with Rheumatological Resilience. What a fantastic topic and what a fantastic write-up or what a fantastic catchy name, which is given by Dr. Neha. She's known for all these things. So many CMEs have given catchy names which are widely accepted and appreciated. Our endeavor at IIP, I like to acknowledge one of our non-IIP, non-Raigad IIP member, Dr. Mahesh Inganmere, was my batchmate at Promise 7. On request, he had joined, and I really appreciate that he is there in this group. Let me tell something about our IIP. Our IIP Raigad is known for celebrating the weeks and the days which are uh, celebrated at central IIP level. And this is something which we are doing for the first time. We are celebrating World Young Rheumatic Disease Day, which was celebrated on 18th of March. And this is to create the awareness about the rheumatological and immunological disorders. So to decode the mysterious disease of rheumatology and immunology, we have got our own speaker, Dr. Rachna Sambag Madam. And Apollo Hospitals, Navi Mumbai. Madam has done MBBS from MJ Medical College, Navi Mumbai, and MD from Kashibai Navle Hospital, Pune. After she has done fellowship in pediatric immunology and rheumatology at Aster FPID fellowship, that is Foundation for Pediatric Immune Deficiency, USA. She has also underwent training at PGI Chandigarh with Dr. Sujit Singh. She has also completed ULAR and Press Rheumatology courses. She was awarded as a Chancellor's Award for the Best Outgoing Student of MBBS batch 2010 to 2016. She represented India at a APSID Junior at 20th Biennial Meeting of European Society of Immunodeficiency, that is ESI 2022. She has several publications in national peer-reviewed journals. She is a great academician and having great insight in managing immunological and rheumatological disorders. With this short introduction, I request Dr. Rachna Madam to kindly start her presentation.
Thank you, sir. I'll just share my slides.
Oh, Gala.
Are my slides visible?
Yes, Rachna.
And I'm
Hi,
audible at you?
Yeah.
Okay. Very good evening to each one of you. At the outset, I'd like to thank IIP Raigad, Dr. Vikas More sir, Dr. Wankhede sir, and Dr. Abba Sahib sir for giving me this opportunity to present on this platform. It's a late evening, but I'm glad to see that so many of you have joined to be a part of this meeting. So today's topic that has been assigned to me is decoding immuno and rheumatology for case-based discussion and few pointers from cases that we see on our day-to-day basis. So the objective of my talk today would be to have a case-based approach to give you few pointers from which you can recognize children who present to your OPD with rheumatologic disorders. Also, I would be discussing few cases of primary immunodeficiency and provide you with an algorithmic approach to make it simple for a pediatrician practicing at any part to just look at these few pointers and these algorithms and identify patients that require treatment especially for primary immunodeficiency. So let us begin with the first case. We have here a 5-year-old girl who has come to the pediatrician with complaint of pain in abdomen for the past 3 days. It's a severe colicky pain and she seems very troubled, as also the mother is very troubled with the pain in abdomen. She receives some symptomatic treatment and is sent back home. However, 5 days later, the mother comes back again that the child continues to have colicky abdominal pain and has also passed some blackish stools, possibly melena. Now, when the pediatrician has a closer look, he notices that this child has developed some rashes over the lower limb extending up to the buttock region. If we have a closer look at these rashes, and if I were to describe them, they are erythematous purpuric rashes, which I am sure on palpation would be even palpable. So now you have a 5-year-old child who has had one episode of melena, severe abdominal pain, and has come to you with palpable purpura. I need not tell you the diagnosis, but let us have a look at the investigations. The CBC here shows hemoglobin of 10, counts of 10,600. There is some thrombocytosis. CRP and ESR are elevated. And once the pediatrician gets an occult stool blood, he finds that it is 4+ positive. USG abdomen shows bowel wall edema and urine routine is normal. A skin biopsy is performed and that shows leukocytoclastic vasculitis with IgA deposits. I'm sure we all know the diagnosis by now. This is IgA vasculitis, or what we also know as Henot-Schonlein purpura. Henot-Schonlein purpura is a small vessel vasculitis, meaning to say it involves the postcapillary venules. It is inflammation at the postcapillary venular level. It is usually seen among children between 3 to 15 years of age and more predominant in females. We often know that the classical triad of HSP is joint pain, purpuric rashes, and abdominal pain. But what we also must know that 1/3 of these patients have renal involvement, and it is the renal involvement that causes long-term morbidity in these patients. Important pointer is if you have identified a child with HSP, that child should be on follow-up with you for at least 6 months with a monthly urine routine, because it is the first 6 months that are very crucial and highest chances of developing nephritis. Few other things that I'd like to point out here are sometimes these children may not come with palpable purpura. They can also present to you with urticarial rashes. So the initial presentation could be urticaria associated with abdominal pain. It is very difficult at this point to identify these patients because urticaria itself can have some amount of abdominal pain. In such cases, getting a stool occult blood in these patients can point you towards a diagnosis of HSP. Also, another soft pointer is presence of subcutaneous edema at various sites. As you can see in this picture, this child seems to have edema over the forehead. So this is also another presentation of HSP that one can identify on OPD basis. Few bad prognostic markers are age more than 7 years, persistent purpuric lesions lasting more than 4 weeks, severe abdominal pain, decreased factor 13 activity, hypertension, and renal involvement at presentation. So those are the few children that require more immunosuppression. So the key message here that I'd like to stress upon is child with severe abdominal pain, with or without history of melena, with or without history of purpuric rashes, one must consider the diagnosis of Henot-Schonlein purpura. Moving on to the second case, this is a 3-year-old girl who has come with history of fever for 6 days, redness of eyes for 3 days. She has received antibiotics on OPD basis but hasn't responded to the same. Now, this is a very classical picture and also a spot diagnosis. Red eyes and strawberry tongue. We know what the diagnosis is. But let us also look at some other soft markers of this disease. As you can see in the perineum and perianal region, there is peeling present. And sometimes these children can also have BCG site reactivation. Yes, everyone, this is Kawasaki disease. Apart from the classical signs and symptoms that we all know of, red eyes, strawberry tongue, we must also make an effort to look at the perineum and the perineal region to look at these sites of peeling. Let us look at another case. This is a 6-month-old boy. He has come with history of fever for 10 days and excessive irritability. On examination, the only positive finding you note is a posterior cervical lymphadenopathy. This child has again received treatment for the same on OPD basis. However, despite receiving antibiotics for a week, has not responded to the same and continues to have fever. Now, the CBC here shows anemia, neutrophilic leukocytosis, and remarkable thrombocytosis. Usually in infections, I'm sure we all know, we don't see this kind of remarkable thrombocytosis in patients. Apart from that, this child has elevated CRP and ESR with abnormality in SGOT and SGPT, and the blood culture has been sterile on several occasions. Now, you have an infant who is not responding to antibiotics, having ongoing fever, no other classical signs and symptoms, but presence of thrombocytosis, high elevated inflammatory parameters, one must get an echo done in such children. And to our surprise, in this child, the echo showed mild pericardial effusion with dilated LMCA with a Z-score of 6, and the RCA had a Z-score of 3.9. This child had moderate aneurysm of LMCA and small aneurysm of the RCA. So now you have an infant with Kawasaki disease. Whenever we have an infant with Kawasaki disease, the upfront treatment remains IVIG with steroids, especially with coronary artery involvement. However, to the bad luck of this patient and his parents, he did not respond to the same. Fever persisted despite receiving the above treatment. So now we are dealing with not only infantile Kawasaki disease, but this is resistant infantile KD with coronary artery aneurysm, extremely high risk patient of Kawasaki disease. As you can see, the CBC, it continues to show anemia. There is no significant neutrophilic leukocytosis now, but what is glaring at us is this kind of thrombocytosis of 10 lakhs. And the CRP has slightly decreased, but still continues to remain high. A repeat echo now shows increase in the size of aneurysms, and now we have giant aneurysm of the LMCA and moderate aneurysm of the RCA. In such cases, we go ahead and increase the immunosuppression and give these children injection infliximab, after which the fever subsided. And he was discharged not only on oral steroids, but along with that, aspirin. And since he had a giant aneurysm, he was also started on low molecular weight heparin. KD, as we know, is a medium vessel vasculitis that affects children less than 5 years of age. However, all children may not present to you with classical clinical features because these features develop over a period of time. Infantile KD is a high risk case of Kawasaki disease as they have high risk of developing coronary artery aneurysms. Treatment remains IVIG and aspirin, and sometimes despite treatment with IVIG, more than 25% of children and more than 50% of infants, especially below 6 months of age, go on to develop coronary artery aneurysm. This is to stress that if you see an infant with Kawasaki disease, it is a high risk case and definitely requires repeated echoes and may also require increase in immunosuppression.
Yeah, madam.
Please stop. Please stop. Please stop. Rachna, please stop. Baba, can somebody mute these people? All of them.
Still, I'm asking Neha.
Yeah. Neha, please mute everybody. Neha,
Yes, sir.
please mute everybody. A lot of disturbance. Please. Yeah, go ahead, Rachna, please.
So in cases of infantile Kawasaki disease, one needs to be more vigilant, and the point here is not only to perform repeated coronary artery aneurysm evaluations, but also to be aware that these children usually do not respond to only IVIG and require further immunosuppression. Since we are talking about KD, we must also talk about this case. This is a child who presented to us with a strawberry-like strawberry tongue and these kind of rashes. Now, some might say this is also Kawasaki disease. But if you have a closer look at these rashes, this is the classical sandpaper rash that was present all over the body. This is not Kawasaki disease. This is what we know as scarlet fever. So this can be a very close mimic of Kawasaki disease. But few things how we can differentiate between both of them is usually in scarlet fever, the entire skin is involved from head to toe. And when they peel everywhere, unlike like Kawasaki disease children, which only peel in the periungual region. So the key message here is fever with red eyes, infant with fever more than 5 days not responding to antibiotics, fever with BCG site reactivation, one must think of Kawasaki disease. I'm sure all of us have seen a fair share of pyrexia of unknown origin. So let us discuss a few cases here. We now have a 4-year-old girl who has come with history of fever for 4 weeks, and rashes which are waxing and waning. The mother classically says that the rashes come during episodes of fever, and as the fever comes down, the rashes go away. This is what we call as evanescent rashes. On examination, this girl has generalized lymphadenopathy and mild hepatosplenomegaly. Her evaluation performed over the last few weeks show anemia, significant neutrophilic leukocytosis to the tune of 35 to 38,000, and as you can see, some amount of thrombocytosis is also present. High CRP and ESR, however, blood culture has been sterile on a few occasions. Now, whenever we see a child coming with fever for 4 weeks with rashes, so fever with rashes ongoing for 4 weeks, the few possibilities that we often consider is this some kind of chronic infection? Is this a malignancy, or are we dealing with an autoimmune disorder? So for infections, we evaluated her for brucella, rickettsia, leptospira, and even tuberculosis. For malignancy, CT chest and abdomen was performed, and bone marrow biopsy was also performed, and both were normal. So is this an autoimmune disorder? However, the ANA biopsy that was performed was negative. Now, some might say if the ANA is negative, if it might not be an autoimmune disorder. But let me bring to your notice that whenever you see these set of symptoms, fever, rash, lymphadenopathy, organomegaly, along with high ESR and CRP, neutrophilic leukocytosis, thrombocytosis, in the absence of any other infection or any other diagnosis, we label these children as systemic juvenile idiopathic arthritis. Why do I say absence of any other infection? Because SJI is a diagnosis of exclusion. Let us discuss another case. This is an 11-month-old boy who has presented with intermittent fevers for the past 1.5 months. Now, this child has also come with complaints of joint swelling for the past 20 days. He has received treatment with IV antibiotics for 2 long weeks, but no response, and was referred to our center as a case of PUO. On examination, he has hepatosplenomegaly, and as you can see, the ankle is swollen, that is, he has left ankle arthritis. Let us have a look at the CBC. He shows presence of anemia, again neutrophilic leukocytosis with thrombocytosis, high ESR, high CRP, normal RFT, LFTs, and blood culture has been sterile. Again, he was worked up as a case of PUO, where workup for all infections were found to be negative. Echo was normal, CT chest and abdomen was normal, and a bone marrow biopsy was performed, which was also normal. We were possibly considering a diagnosis of SJI. However, during the course of his illness in the hospital, this child developed high-grade fever spikes. His hemoglobin has now dropped to 4. Counts have been showing a decreasing trend, and platelets have decreased from the tune of 8 lakhs to 4 lakhs and now 1,50,000, and possibly even decreasing further. He has a high CRP. ESR is around 70. However, ferritin is 70,000. We performed a ferritin in the presence of his ongoing pancytopenia. Fibrinogen was low and SGOT-PT seemed deranged. A bone marrow biopsy was performed in this child, and what was seen was presence of histiocytes. So whenever you have a serum ferritin of 70,000, as high as 70,000, in the presence of fever, organomegaly, cytopenias, high ferritin and hypofibrinogemia, we know that the diagnosis is macrophage activation syndrome. So let us have a look at the criteria for MAS. MAS is known to be present in patients with known or suspected systemic juvenile idiopathic arthritis when the criteria for ferritin is more than 684 and presence of any two of the following. In our case, the platelets were low, AST was elevated, triglycerides of more than 156, and in our patient, he also had low fibrinogen. Now, one might say that why is the criteria for MAS slightly different as compared to the HLH criteria? In the HLH criteria, as we know, the ferritin cutoff is 500. However, it is slightly higher in MAS. This is because in patients with autoimmune disorders, their baseline ferritin itself is high. So during episodes of MAS, it increases further. Also look at the platelets. The cutoff for platelets is less than 1 lakh in patients of HLH, whereas it is 1,80,000 here. That is because, again, these patients tend to have a baseline thrombocytosis. And when the platelets start decreasing, the criteria has been made such that one should not wait till they drop below 1 lakh. So now here we have a case of MAS in a case of systemic JI. And this child had to receive treatment with high dose injection methylprednisolone, after which his counts recovered. his arthritis improved and fever subsided. So systemic GI, as we know, is also an autoimmune disorder. It is a diagnosis of exclusion, and we know that the interval between the onset of systemic signs and appearance of arthritis can be as long as 10 years. So upfront, these children may not come with arthritis. They have high ESR CRP with thrombocytosis and change in pattern of fever, falling ESR or platelet counts. One must think of macrophage activation syndrome. So the key message here is in cases of PEO, if there is fever ongoing beyond 4 to 6 weeks and you have excluded all possible infections, if there is present of arthritis, rash, raised inflammatory parameters, one must evaluate for a possibility of a connective tissue disorder. Moving on, now we have a 10-year-old girl. She has been unwell for the past 3 months with intermittent fevers and rash over the face for 1 month. Let us have a look at her. As you can see, this is a classical butterfly rash which is hyperpigmented, involving even the nose and along the malar area. When we open her mouth and examine her hard palate, what we see are petechiae present over the hard palate. What you should also notice here is presence of alopecia, which is of non-scarring type. Investigation showed presence of anemia, leukopenia with lymphopenia. CRP was negative, but ESR was elevated. ANA by IS was 2+ positive, and the ANA profile showed presence of anti-dsDNA and anti-Smith antibodies along with low complement levels. We know the diagnosis here is systemic lupus erythematosus. So adolescent girl coming with malar rash, oral ulcers, leukopenia, high ESR, positive ANA and hypocomplementemia, we know that the diagnosis here is SLE. Also, another characteristic finding is presence of CRP negative with an elevated ESR. In infections, we know both are elevated. This is one of the few conditions in which CRP will be on the lower end, but ESR will be elevated. SLE is a chronic autoimmune disease involving multiple systems with inflammation due to circulating autoantibodies that are directed against self-antigens. They are predominantly present in females, and the median age of diagnosis is around 11 to 12 years, and they rarely present below 5 years of age. And we know that they have oral ulcers which are not painful. Hence, they usually do not complain of these ulcers, and they are often noticed only when we examine the oral cavity. And this is the classical butterfly rash that we see present in SLE patients. Moving on to the next case, this is a 8-year-old girl who has presented to us with cola-colored urine for last 3 days. She has periorbital swelling and some remote history of sore throat 2 weeks back. On examination, she has bilateral periorbital edema, pedal edema, and also hypertension. Investigations show elevated creatinine. Urine analysis shows presence of RBCs, RBC-CAS, as well as proteinuria. ASO titers are elevated. And as you can see, the complement levels, C4 is normal, but C3 is low. Needless to say, we know the diagnosis here is post-streptococcal glomerulonephritis. However, after receiving treatment for the same, few weeks later, this child comes back with this atypical rash present only over her cheeks. When we examine her oral cavity, we notice that she also has hard palate petechiae. CBC now shows anemia with leukopenia, very high ESR, and now the C3 and C4 both are low. So this combination of having a girl with malar rash, oral ulcers, hair loss, we know this is SLE. But in the presence of hematuria, edema, hypertension, low C3, it is nephritic syndrome, and this is a case of SLE with lupus nephritis. The point I would like to make here is we often see cases of acute GN or PSGN in our OPD. However, on follow-up, if they continue to have hypocomplementemia or come back with systemic features, that is the point where we must consider evaluating them for underlying autoimmune disorder. We know that hypocomplementemia in PSGN lasts for about 4 to 6 weeks. However, persistence of low C3 and even low C4 beyond this point, one must evaluate for underlying SLE. So, in cases of acute GN with persistently low serum complements beyond 12 weeks, systemic features such as malar rash, oral ulcers, and delayed resolution of glomerulonephritis, one must think of SLE nephritis, and these are the cases where we must go ahead and perform a renal biopsy. Moving on to another case, this is a 3-year-old girl who has come with history of limping for the past 2 months. There is no fever, just a left knee which is swollen as you can see in the picture. Her CBC is normal, inflammatory parameters are also normal. In these cases, when we have monoarticular involvement, the first possibility that we often think of is tuberculosis. The second is hemophilia. And the third is this juvenile idiopathic arthritis? For tuberculosis, she was evaluated for MON2 and even a chest X-ray was performed, but both were normal. Though she was a girl child, we did perform an evaluation for PTNR and APTT, which was also normal. And what we remain is this JIA then? So whenever we see this kind of combination, young girl with fewer joint involvement, predominantly lower limb joint involvement, the diagnosis here is oligoarticular juvenile idiopathic arthritis. Oligo-JIA is when there are less than or equal to 4 joints involved. Knee is the most common affected joint, and these are usually toddlers or preschool children, girls more than boys, who come with monoarticular or few joint involvement of the lower limb. And what is important here is to perform an ANA, because a positive ANA indicates that they have high risk of developing uveitis, and these are the children that must visit an ophthalmologist for evaluation of uveitis. So here I'd like to end my rheumatological cases. And since we recently celebrated the World Young Rheumatic Diseases Day, this is to create awareness among practitioners, among pediatricians, to diagnose and pick up these children early. Because not only receiving treatment early helps in their prognosis, but also prevents them from leading a life with disability. Moving on to primary immune deficiency. We initially thought that primary immune deficiencies are children who have an immune disorder and are prone only to develop recurrent infections. However, now we are wiser and we know that it is not only recurrent infections, but also autoimmunity and malignancy that can be their presenting symptom in these children. And therefore, now we term them as inborn errors of immunity. Now, the Jeffrey Model Foundation has made an attempt to give us few clues that we can use on OPD basis to recognize these children. Let us have a look. 4 or more new ear infections within 1 year, 2 or more pneumonias within a year, persistent thrush in the mouth, family history of PID, 2 or more serious sinus infections within a year, failure of an infant to gain weight and height, need for IV antibiotics to clear infections, 2 or more months of antibiotics with little effect, presence of deep-seated infections such as deep skin or organic abscesses, and 2 or more deep-seated infections including septicemia. So these are few of the pointers which help us to recognize these patients so that they can be screened for underlying PIDs. Now, what are the common clinical presentations of these children in OPD? They can come to you with recurrent sinopulmonary infections involving the sinuses, or can present with pneumonia, empyema, can come to you with suppurative infections such as a lymph node enlargement, can come to you with abscesses, can come to you with colitis, dysentery, disseminated BCG infection, skin infections or eczema, or recurrent candidiasis. So in the next few slides, I'd like to show you a case on each of these presentations. However, before we proceed with the cases, every case we must approach in this pattern. What is the age of presentation? What is the family history of this child? What is the type of pathogen that we have isolated from this child? And what is the type of infection? Let us have a look. Coming to recurrent sinopulmonary infections, we have a 4-year-old boy who has come with history of 3 episodes of pneumonia in his lifetime. Now, whenever we look at recurrent pneumonia, I'm sure there are other possibilities that come to our mind, such as a congenital heart disease, cystic fibrosis, maybe a congenital lung anomaly, GERD. So he was evaluated for each of these. Echocardiography was done, which was normal. Bronchoscopy BAL was sterile. CT chest did not show any lung anomaly. A sweat chloride test was done to evaluate for cystic fibrosis. A nuclear scan for GER, and even an HIV rapid CAR test was done to rule out underlying immunodeficiency, that is HIV. Now, when we have a look at his past history, it indicates that he's not only had pneumonia, but has also had 2 episodes of otitis media at 15 months and 2 years of age. Meaning to say, this child has come with recurrent sinopulmonary infections. His family history shows that there is death of 2 male siblings as well as few maternal uncles. meaning to say this is an X-linked disorder. And on examination, we see that there is absence of tonsils in this boy. Immunology workup shows that he has low immunoglobulins, that is pan-hypogammaglobulinemia, and a lymphocyte subset which evaluates for T cells, B cells, and NK cells shows that there is absence of B cells. We know that B cells are the one that produce the immunoglobulins. Therefore, this child not only has absence of the B cells and therefore also has pan-hypogammaglobulinemia. We know the diagnosis here is a boy with an X-linked disorder with hypogammaglobulinemia and absent B cells. This is X-linked agammaglobulinemia. XLA is also known as Bruton's agammaglobulinemia, primarily affecting the boys. They come to you with recurrent pneumonia, otitis media, diarrhea, skin infections. Classically have absent tonsils and lymph nodes, low immunoglobulin levels, and absent B cells. The mutation is in the BTK gene, and treatment remains monthly IVIG. We know now that with monthly IVIG, they can even go on to live as normal as other adults. Let me explain to you where is the etiopathogenesis of XLA. We know that the bone marrow has stem cells, and these stem cells give rise to B cells. B cells then mature to form plasma cells, and plasma cells give rise to IgM, which by class switch further form IgG, A, and E. However, when there is a defect in the ability to produce B cells, this is what we call as X-linked agammaglobulinemia, as a result of which they not only have absent B cells, but they also have low immunoglobulin levels. However, if the defect is in the maturation of B cells, that is B cells maturing to plasma cells, this disease is known as CVID or common variable immunodeficiency, where the B cell numbers may be normal, but the immunoglobulin levels are low. So whenever we see a child with recurrent sinopulmonary infections or bronchiectasis due to recurrent pneumonia, we must evaluate them for serum immunoglobulin. Now one might say that these are costly tests, but if you see that these children land up undergoing so many CT scans, in that case, a simple test as a serum immunoglobulin can help you clinch the diagnosis in these cases. If this is a boy with hypogammaglobulinemia, look at the B cells. If the B cells are less than 2%, the diagnosis is XLA. Whereas if the presentation is in an adolescent or an adult with hypogamma but normal B cells, we know the diagnosis here is CVID. Moving on to suppurative infections. So this is a 6-year-old boy who has come to us with a large submandibular swelling which looks red and inflamed, possibly even has pus inside it. Now at 2 years, he had an episode of empyema, and at 4 years, he has also had liver abscess which isolated Pseudomonas. CBC shows anemia, neutrophilic leukocytosis on multiple occasions, and significant thrombocytosis. Now the lymph node aspirate has grown Staphylococcus aureus. So the age of this child is 6 years. This is a boy. The pattern of presentation is suppurative infections. The type of pathogen that we are looking at are like Staphylococcus and Pneumococcus and Pseudomonas. Now let us have a look at the immunological workup. The immunoglobulins here show high levels. That is, this child has hypergammaglobulinemia, and lymphocyte subsets are normal in this case. Whenever you see a child with suppurative infections with this kind of presentation, one must order a simple test, that is an NBT, and the other test is called a DHR. NBT is a nitroblue tetrazolium test that detects the absence or the defect in NADPH oxidase mechanism of the neutrophils. Now, NADPH mechanism is a mechanism by which the neutrophils are able to deal with intracellular organisms. If there is a defect in this mechanism, they are prone to developing infections with intracellular organisms, and therefore the NBT test will be normal. That is, the dye used in this test will not be reduced. So these are the neutrophils, or which on staining should have become dark blue, or formazan stain should have been dark blue in color. However, in patients with CJD, this dye does not get reduced because defect in NADPH oxidase, and what we see are plain neutrophils. Another test, that is dihydrorhodamine assay, is also abnormal in these cases. And what we are looking at is a chronic granulomatous disease, which is a phagocytic defect. So children presenting to you with recurrent suppurative infections like empyema, deep-seated abscesses, lymph node abscesses, in the presence or past history suggestive of unusual pathogens like Pseudomonas, Aspergillus, Nocardia or Burkholderia, one must look at the CBC. And if you look at neutrophilic leukocytosis, thrombocytosis with hypergammaglobulinemia, please ask for an NBT-DHR. And if the NBT-DHR is abnormal, we are reasonably sure this is a case of chronic granulomatous disease. CGD, as I said, is a phagocytic defect in the NADPH oxidase, which cause defective intracellular killing of engulfed organisms. They give rise to suppurative infections. NBT-DHR is abnormal, and the treatment here remains antimicrobial prophylaxis, and definitive treatment is a bone marrow transplant. Moving on to recurrent or non-healing ulcers. Now, this infant has come to us with non-healing ulcers for the past 3 months. As you can see, there is an ulcer at the base of the nose, even on the neck, and even in the buttock region. However, classically, each of these ulcers do not show any pus formation. They are non-healing because for last 3 months, the child has been having these ulcers. She also has some amount of recurrent diarrhea. And classically, the mother says that there was a history of delayed cord fall. When we look at the CBC, we see that she has remarkable neutrophilic leukocytosis. Unlike in cases of CGD where the counts are in 20,000s and 40,000s, here you can see that the counts have even gone up to 1,40,000 with neutrophilic predominance. There is also some amount of thrombocytosis in the background. When we see this combination of presentation, delayed cord fall, recurrent ulcers, neutrophilic leukocytosis, the diagnosis here is a leukocyte adhesion deficiency. And when we perform the CD18 expression, that is the adhesion molecule present on the neutrophils, it was absent in this patient as compared to the control. And the genetic test showed presence of mutation in ITGB2 gene. LAD is a defect in adhesion of neutrophils to the endothelium. So though the neutrophils are brought near the site of infections, since they are not able to adhere to the endothelium, they are not able to reach the site of infection. Therefore, their numbers are increased in the bloodstream. These children have delayed history of cord fall, omphalitis, non-healing ulcers, recurrent pneumonia and diarrhea. Classically, there is no pus formation as the neutrophils are not reaching the site of infection or ulcer. They have persistently high neutrophilic leukocytosis even in the absence of infection. Now, this is a great pointer to identify these patients because even when they are well, they will continue to have high neutrophilic leukocytosis. And the treatment here remains antimicrobial prophylaxis with bone marrow transplant. Moving on to the next case, this is a 7-year-old boy, and he too has come to us with recurrent oral ulcers. However, these ulcers come on a monthly basis, lasting for about 3 to 5 days, and in between these episodes, the child continues to remain well. There have been 2 episodes of otitis media in the past, and on examination of his oral cavity, you can see that he has significant amount of gingivitis. If we look at a CBC trend, we find that on occasions he shows presence of low neutrophil count. That is, the absolute neutrophil count is low on few occasions, whereas it is normal in between. Unlike the previous case where recurrent ulcers was presenting with neutrophilic leukocytosis, here we have a child with neutropenia. When we plot the ANCs on a chart, we find that every 3 weeks there is a drop in the neutrophil counts. And it is during these episodes that this child develops otitis media and these episodes of oral ulcers. This is what we call as cyclic neutropenia. If we perform a bone marrow biopsy during the episode of neutropenia, we find arrest in the myeloid maturation. Cyclic neutropenia, the neutropenia occurs every 21 to 25 days and lasts for about 3 to 5 days, after which it recovers. During the nadir is when they develop these infections, and it is a mutation in the ELANE gene which is causing this disease, and the treatment here remains GCSF therapy. So coming to the algorithm, recurrent ulcers and infections look at the absolute neutrophil count, persistent neutrophilic leukocytosis, no pus formation, the diagnosis is LAD, whereas in presence of neutropenia, whether persistent, then we call it severe congenital neutropenia. If it is cyclic, we call it as cyclic neutropenia. Moving on to the next presentation. I'm sure most pediatricians see this on a daily basis, children coming with recurrent candidiasis. This is a 5-month-old boy who has come with oral thrush and even presence of fungal infection in the genital region. When we look at his family history, he's born out of consanguineous marriage, and there is an history of death of a female sibling at a very young age. Now, when we see an infant coming with this kind of infection, that is recurrent oral thrush, or infections with opportunistic pathogens associated with failure to thrive, the two possibilities we must consider is HIV and a T cell defect, or rather a severe T cell defect presenting in infancy, such as SCID. Investigations show that HIV rapid card test is non-reactive. However, in CBC, what we notice is this child has lymphopenia on multiple occasions. The normal lymphocyte count in infants is above 3,000. However, in this child, the ALC is around 500 to 600. When we look at the X-ray, we can see classically the thymic shadow that is usually seen in infants is absent in this case. So the approach here is infants coming with infections, oral thrush, failure to thrive, with presence of persistent lymphopenia and absent thymus. The diagnosis is severe combined immune deficiency. And we have come to this diagnosis even without performing a single immunological test. This is one of the common PIDs that present in NICUs. Whenever we see a patient in the NICU with infections, but with presence of lymphopenia, one must consider a possibility of SCID, getting a chest X-ray to look at the thymic shadow, and looking at the serial CBCs for lymphopenia can guide you to the diagnosis. Now, the immunoglobulins here are low, whereas the lymphocyte subsets show that the T cell and NK cells are low, whereas the B cell is normal. This is what we call as T minus B plus NK minus SCID, which is also a variant of SCID. And the genetic test was mutation in JAK3 gene. SCID, as we know, is the most serious form of immune deficiency. It is a medical emergency. They present within the first year of life, and if they do not receive definitive treatment, that is a bone marrow transplant, it is 100% fatal in these cases. The classical presentation is lymphopenia, low T cells, and hypogammaglobulinemia with absent thymus on chest X-ray. Message here is recurrent oral thrush in an infant. Please do have a look at the ALC count, and if there is lymphopenia, one must evaluate for SCID. Moving on to the next presentation, that is disseminated BCG. Now, this child is a 3-month-old boy who had received BCG vaccination, following which he developed some BCG site erythema and swelling, and subsequently developed a left axillary lymphadenopathy. He was thought to be BCG adenitis and was given symptomatic treatment. However, few weeks later, he started developing this papular rash all over the body. This kind of triad of BCG site swelling, left axillary lymphadenopathy, and diffuse papular rash is a diagnosis of disseminated BCG. And disseminated BCG is a primary immune deficiency unless proved otherwise. Many PIDs such as SCID, CGD, and MSMD, that is Mendelian susceptibility to mycobacterial infection, can have disseminated BCG as the presenting symptom. In a country like India, where all our children receive BCG vaccination, this could be the first presentation of any of these PIDs. We performed a genetic test in this child, and this child had a mutation in IFN gamma R1 gene, which is a causative gene for Mendelian susceptibility to mycobacterial disease. MSMD is a type of PID in which they are prone to developing infection with non-virulent or weakly virulent mycobacteria, unlike tuberculosis. So the question here is BCG adenitis, when should one investigate? We know that localized adenitis is known to occur in a small subset of even healthy children and does not require any immunological evaluation. However, if there is BCG adenitis in presence of disseminated BCG, or if there is an underlying immune deficiency, or if the child is suspected to have a PID, or has been having recurrent infections, or has a significant family history, these are the pointers where one should go ahead and further evaluate for PID. Coming back to the next common presentation, that is colitis or dysentery. This 8-month-old boy, right from 4 months of age, has been having recurrent episodes of diarrhea. And during each episode, he receives either antibiotics or symptomatic treatment. However, on examination of the anal region, we find that he not only has a fissure, but also has an anal tag. And the opening is red and erythematous. CBC shows hemoglobin of 10 counts are elevated. There is significant thrombocytosis with high ESR and CRP. A fecal calprotectin is done in this child since there were presence of fissures and anal tag, and we find that the fecal calprotectin is elevated. This child subsequently underwent a colon biopsy and the diagnosis of inflammatory bowel disease was confirmed. Whenever we see a child less than 6 years of age presenting with IBD, we call this as a very early onset inflammatory bowel disease. And we know this is a monogenic disorder. And if we perform genetic testing in these children, one of the genes that one can find is IL-10RA gene. And the treatment here needs steroids, mesalamine, and curative treatment remains a bone marrow transplant. So this is what we call as monogenic IBD. They are usually refractory to routine immunosuppression, and there is some role of performing a bone marrow transplant. Coming to eczema and skin infections. This is a 5-year-old boy, and as you can see, he has extensive molluscum contagiosum lesions all over his face and even on the body. He's a third born of a consanguineous marriage. CBC shows eosinophilia on multiple occasions, and a serum IgE was performed, which was extremely high, that is more than 3,500. Let us look at another case. This is a 2-year-old boy, and he has come to you with chronic eczema. So much so that the mother says that he hasn't slept for days together in the night due to the itching. He has received steroids on multiple occasions, but has not been responding to the same. When we examine his gums, we notice that he has hyperpigmented gingiva. CBC shows eosinophilia and very high elevated IgE levels. There has been some background history of low-grade infections such as pyoderma. Now, in both these cases, whenever we come across either extensive viral infections such as warts, molluscum contagiosum, herpes, or chronic eczema, in the presence of eosinophilia and high IgE, one must consider a diagnosis of hyper IgE syndrome, the autosomal recessive variant. When we performed a genetic test in these cases, both these children had DOC8 gene deficiency. And this is what we call as AR hyper IgE syndrome or DOC8 deficiency. Treatment here is monthly IVIG, antimicrobial prophylaxis, and if treated early, they can also undergo a successful bone marrow transplant. So coming back to my slide, PIDs are about recognizing the pattern. If it is an infant with recurrent infections, one must consider SCID, whereas between 6 months to 1 year, where the maternal immunoglobulin has faded away, that is when these XLAs usually present. LAD is also present during this period. PIDs presenting in adult age are CVID and MSMDs can present at any age. Coming to family history, if there is an X-linked pattern, it is XLA or Wiskott-Aldrich syndrome. AD pattern, then it is Job syndrome. Autosomal recessive patterns can be the presentation of SCID, CGD, DOCA deficiency. Coming to the type of pathogen, usually in T cell defects, they have infections with opportunistic pathogens. In CGD, which is a phagocytic defect, they will have infections with intracellular organisms like Staphylococcus, Nocardia, Burkholderia, and Aspergillus. And we know that in complement deficiency and antibody deficiency, they routinely have infections with pneumococcus and meningococcus. Coming to the type of infection, children with recurrent sinopulmonary infections, we must think of antibody deficiencies like XLE and CVID. If there are suppurative infections, these are due to phagocytic defects like CGD. And if there is disseminated BCG, there are several PIDs which can come with this, that is SCID, CGD, and MSMD. I'd like to end my presentation. Thank you for your attention. And these are my contact details. I'm happy to take any questions if there are any.
Excellent, Rachna madam. What a beautiful presentation. You have given complete insight to the immunological and rheumatological disorders. Because a maximum of a session, 45 minutes, you have covered so many cases which are garden variety cases. Actually, it's very difficult for us to assimilate each and everything which you have spoken. But definitely, it is quite sensitizing, and definitely we will take this forward and try to learn many things from you, as well as many things from the references which are available. It is always said that eyes can't see what mind doesn't know, and this is true for the immunological cases. So there are no much of a questions which I could see in this chat box. As your presentation was quite lucid and you have given a very algorithm based of approach. If anybody has got any questions, they can directly ask the madam.
Ava,
Yes.
hello.
Yes, yes, yes.
I have got one question. I have one question to Rachna ma'am. In KD or incomplete KD, there are few signs and symptoms which is not conclusive. In that case, can we go for hypoalbuminemia as a negative marker, inflammatory marker?
So firstly, please don't call me ma'am. I'm very, very junior to you, sir. And very, very good question, sir. Incomplete KDs are those KDs which are the most difficult and tricky to treat because they don't come with classical signs like red eyes and strawberry tongue. So our confidence to go ahead and treat like KD is always low in these cases. But few pointers, like if there is an infant with fever ongoing for more than 5 days without any classical features, or if you have a child with raised inflammatory parameters, please look at the CBC. If there is some amount of thrombocytosis, that is one soft marker. Your question about serum albumin. So even in the algorithm that has been provided by the SHARE guidelines, they mention that if the albumin level is low, that is less than 3, that can be considered as one of the pointers to treat for KD, along with obviously the other markers such as presence of anemia, neutrophilic leukocytosis, thrombocytosis, elevated ALT, and any 3 out of these along with presence of fever for more than 5 days, one must go ahead and do an echo and can treat as a case of IVIG, especially in incomplete Kawasaki disease.
Thank you, madam. Thank you very much.
Madam, there is a lot of surge of cases which we see, like a scarlet type of presentation, or maybe some sort of a spectacles pharyngitis, or maybe adenovirus, or maybe some sort of a viral pharyngitis, where we see a lot many cases, digestive nodes, and the rare may not be typical of a scarlet fever. As you said, in scarlet fever, there's a peeling of a whole of a skin, and not only the peeling. So in that cases, which are the cases which would be missed in those plethora, where you can pick up on 1 or 2 points, where you can go ahead with echocardiography, because lot many patients, lot many parents pressurize us to go ahead with some, and if you miss on that, and somebody goes and find out that viral testing, it's a big basically problem. So just tell us how to differentiate the scarlet and Kawasaki, and which are the patients whom we should go ahead with 2D echo.
Yes, sir. So, sir, very valid question because now we also have adeno in the picture, which comes mimicking Kawasaki disease because it comes with fever more than 5 days with red eyes. And as you said, we have been seeing a surge of scarlet fever, and that is why I also showed the picture of a child who recently presented to us with scarlet fever. So, some soft indicators where we can differentiate between KD and scarlet fever is, like I mentioned, they will also have strawberry looking like tongue, scarlet fever. But however, the rash that is present in scarlet fever is classically sandpaper. And as they progress or as the fever goes on, this rash is involving every part of the body, unlike in KD where it will be in patches here and there. Now, KD itself can present with various kinds of rashes. They can come with urticarial rashes, can come with maculopapular rashes, but they do not come with sandpaper rash. And the other one is vesiculobullous rashes. That is another kind of rash that KDs do not come with. So those are the rash can help you differentiate. The second thing, like I said, is when the fever dies off and the peeling starts. In a scarlet fever child, he will peel everywhere, wherever there was a rash. But unlike in a KD child, the peeling will be classically limited to the periangular region in both the fingers as well as the toes. He will not peel over anywhere else over the body. However, I'm sure there will be a subset of patients which will have red eyes, fever, some rash which we are not sure looks like sandpaper. So in these cases, I would rather say that better to get a 2D echo because missing a coronary artery lesion has far more higher implications than getting a 2D echo done. So in these cases, whenever there is doubt, where the classical findings on your investigation, such as neutrophilic leukocytosis or the thrombocytosis has not set in, because usually you get thrombocytosis only in the second week of illness in KD. In these cases, getting a preliminary echo done can always be helpful because if you find a coronary artery aneurysm in this child, your confidence to treat for Kawasaki disease increases much more.
Obviously, madam. And one more thing is the patients who are presenting with a severe acute pain in abdomen, but there are no clinical signs of intussusception, and now still rash and the joint pain has not started. So is this the place where you do a stool routine and you
Sorry, sir, I missed the last part of your question.
the place where you go ahead with a stool routine microscopy and to see blood?
So, sir, those are the most difficult HSP patients who present initially with abdominal pain. Most classical presentation is they come with rash, and within 1 week of rash is when they usually develop abdominal pain. But children who have the reverse presentation, now there have been cases, or I have seen during my fellowship, that these children even undergo surgery for appendicitis because the pain is so severe that an exploratory laparotomy is done in these patients. And subsequently, 3 to 4 days later, they start developing these rashes. So these are very difficult cases, but few soft pointers that can help is, like I showed even in my case, if there is severe colicky pain which is not responding to your symptomatic treatment, and a stool OB, which is a simple test which I'm sure all of us have access to, shows you presence of occult blood. That is one case where you know that there is some amount of inflammation going on in the intestine, because of which there is blood in the stools. In these conditions is where we must be more vigilant to look for these rashes. Sometimes these rashes take time to develop or rather spread. So earlobes are one another region where these rashes can come first, unlike the classical presentation where it can be present over the lower limb and the buttocks. So those are the areas which we often miss in our examination, which can be looked for. And if you find a child with abdominal pain and severe abdominal pain with occult blood, also possibly having melena, those cases we might have to further evaluate for HSP.
Okay. And madam, a few words about ANA testing by immunofluorescence and ANA profile. When to order and how to interpret? And what is
I
the
think
cost?
that's a very, very important question, sir, because there is a high pretest probability in doing a ANA test. So if an ANA test is performed in a general population, we say that around 5% of us can be ANA positive. 5% children are ANA positive even in the absence of an autoimmune disorder. So ANA should be performed only when there is some history or some feature suggestive of an autoimmune disease. And always while performing these investigations, ANA by IF should be performed first. And if it is positive, then we should go and perform a profile. Now, to just explain what is the difference, ANA itself is antibodies against various nuclear antigens. And what ANA-IF does is just tells you whether these antibodies are present or not. We go ahead and perform the ANA profile because we want to know which are these antibodies that are present. So unless you know that the antibodies are present, doing a ANA profile does not make sense. So one must always order for a ANA-IF and then go ahead and order for a ANA profile, especially in a child where there is some suspicion of an autoimmune disorder. One another possibility is when we are evaluating or investigating children with PEO. If we have come to a point where beyond 4 weeks, we know that most infections are not a possibility in this child. Only some chronic infections like brucella or maybe TB can be possible in these cases. After we have thoroughly evaluated for these, those are the times where one can go ahead and perform a ANA in these cases.
Thank you, madam. This is from my side. Anybody else also has got some? Shall I go ahead with closing the session? May I request Nia, madam, to take over? Nia, madam is not there, then
Hello.
Vikas will take it.
Yeah, so on the behalf of IIP Raigad, I am very proud to have our own Dr. Rachna to present a very important area. Like as a pediatrician, we feel that the rheumatology and immunology are different topics, but she has really contributed so well that now she has herself told me that this is a new field where they have combined the rheumatology and immunology together, and now these experts are coming, and she is available in Raigad, so close to us. So we are so happy, and she has presented so nicely in the case-based scenario. It's very easy to learn, and it was a happy learning for us. I am very much thankful, Dr. Rachna, for your presentation. And a proud father-in-law, I can watch Dr. Mahesh Mohity's. He is so proud of you. And we are also proud. Pramod Vankade sir is very instrumental in arranging this seminar. Neha, again, we are so proud of you for your wonderful flyer and your catchy name. And many senior people have joined. I want to want some 2 words from Dr. Mahesh Kumar Hingmare if he is available before we close the session.
Excellent presentation by Dr. Rachna Madam. This is much needed for a general pediatrician like us. Algorithmic approach the madam has told is very good, and this lecture is much needed for general pediatricians like us. Thank you.
Thank you, sir.
And as always, Abbas sir is one of the best moderators of Maharashtra. So, this is another second we rely on him for moderating the session. And at the end, I'm thankful all the members who joined so late. It was slightly late, 9:30 onwards, because OPDs are going on these days. So I myself requested to start at 9:30. So again, thank you everyone. Happy learning. Good night.
We would request Mahesh Mohite sir a few words.
Yeah,
Sir.
please. Sorry, Mahesh Mohite sir, your comments.
So home ground, actually, she, what I understood is she presented probably the very straightforward and the simple of the rheumatology and immunology cases.
Perfect.
But this field is not that simple, I have realized over the years. So these people making it as a super specialty are giving much breakthrough to something really far beyond what we think. I think what's learning point for us as a general pediatrician is to suspect in time and get it evaluated. Over the years, I have been experiencing these cases, seeing more and more cases, and now we are discussing at home as well. And I am absolutely, I always believe I am having hardly any knowledge in this field. It's extremely complex field, especially the immunodeficiency and new autoinflammatories coming in this rheumatological aspect and all those things. I think it's a huge Pandora's box, still in the evolving phase. Like about 5 or 10 years ago, there were hardly about 50 immunodeficiency disorders known, and today we have about 470 or 60. Am I right, Rachna? There are
Yes,
about
sir,
460 disorders known, and with the availability of this whole exome sequencing and all, perhaps we are making more and more diagnosis. But I think this is the never-ending. This is the field of future. I would say genetics and immunology are the field of future. Similarly, the rheumatology, mainly the autoinflammatory disorders coming up, and they are showing different phases. But as a general pediatricians, what she said, perhaps what she showed about 20 odd cases, they are the ones common presentations. And we must remember the first slide which he showed, those 10 suspects of immunodeficiency. You know, even if we have that kind of a chart in our OPD and any child fulfilling those criteria, perhaps get that child evaluated as early as possible. Otherwise, this immunodeficiency, I distinctly remember the cases of, say, congenital HLH or SCID or something. They literally die in hours. They literally die in hours. You miss in the first visit and they die. I've seen those macrophage activation, a PO child, 15 days, 20 days, and you don't have a lead. And I personally experienced the child was absolutely all right till morning. And my somebody was, he's not here. This child was some 17, 18 days. The child I saw about 10 years ago when we were not aware of all these conditions.
Alibag patient.
Fever for almost
Alibag patient. That patient.
Alibag patient. You're right, Mahesh. So that child was some 7 or 8 years old child, only child of, I think, school teachers, and 15, 18 days fever, and had some neurological manifestations, and CSF was showing some borderline things, we were suspecting coughs. And I saw the child in the morning at around at 9:30, 10 o'clock, and the child was bang all right. Morning, for some reason, we had taken the counts and all, was something like 2 lakh platelets and this and all. And suddenly at 11:30, 12 o'clock, he had a hyperparesis spike of 105. And we had tough time getting the fever under control, and child required to be intubated. He became shocky also. And within 2 hours, he was brain dead. And the parameters collected, his ferritin was somewhere like 50,000, and his platelet had crashed within 2 hours from 2 lakh to just 20,000. So macrophage activation, I'm really extremely concerned and worried. So those kind of things are possible only if you suspect these disorders well in time and get them investigated. And those are the horror stories. So that's what I was saying. What Rachna presented is a beautiful picture of rheumatology and immunology, but this is not that simple, and it's extremely complicated structure. I personally believe I know hardly 10 or 15% of this whole field. It's a huge field to learn. Maybe something for future.
But
So thank
as
you very
this
much. It was a wonderful presentation.
has this increased much more following this COVID, or we used to see this before also?
They started recognizing it more, I suppose. I think it was there. If I look back my 30 years of practice, there must have so many cases who were lost simply suspecting it is the registered infection. The commonest cause of death, then the return used to be written is sepsis. And we never, this
Exactly.
macrophage activation, I think we lost so many children in the past. If I look back, many children we lost as macrophage activation. I mean, I distinctly remember one of the physician's child in Panvel itself, that's about 25 years ago, who was a dengue child, dengue girl. And then she would just drop her platelet record, almost 30 platelet packs was shifted to Hinduja, which Sunu Udani for almost a month. And then even they didn't know what's happening. And then Dr. N.D. Agarwal was summoned to see that child because platelets were dropping. M.B. Agarwal never came to Hinduja, but for that child, he went, he collected the smear, and they said it looks like macrophage activation. So they gave, then this the first case of I remember 25 years ago. She received steroids and she quickly came out of it. So diseases were there, but perhaps we are not knowing them. This was there, but we're not. Now, yes, I think the pickup rate is very high. We suspect, we know what is macrophage activation. No, we know, many of us know what is SLE. We know what is SOGI. So at least I would say 50% cases are picked up early. But the remaining 50% are something where we don't suspect, especially immunodeficiency, we don't suspect. Rheumatology, we don't suspect. We are seeing really a good. I'm really delighted to have these two juniors giving me a new exposure at this phase of my life to know something which I did not know. So it's a wonderful feeling to, in a wonderful learning experience going on. Thank you very much.
I think another proud person must be Dr. Kaustubh Murthy, who was joining and leaving in between. Might be busy, but again, it was a very wonderful session. I am proud IIT Raigad is coming with new ideas, and in this coming year, we are having many new academic programs under the able leadership of Babasaheb Patlekar sir. He has huge vision for this year. So you will be watching for these upcoming seminars in every month this year. Thank you so much. Happy learning. Good night.